Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series session. Today's topic is management of HIV-exposed infants and children and management of newly diagnosed HIV infection in children, including ART initiation. And the speaker is Dr. Noella Pereira. Dr. Noella Pereira is working as a consultant in pediatric HIV and telemedicine with Lokmanya Tilak Municipal Medical College and General Hospital, Sion, Mumbai. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Shweta. So good afternoon, friends. Today I'm Dr. Noella Pereira, and I'll be speaking to you on the management of HIV-exposed infants and children and management of the newly diagnosed HIV infection in children. So we shall start right away. This is the scope of my session. We'll be covering various topics such as care of the HIV-exposed infant, ARV prophylaxis in infants, immunization, vitamin A supplementation, growth and development, clinical and immunological staging, evaluation of the adolescent living with HIV, and antiretroviral therapy in children. Quite a long session, but please bear with me. So starting with the first part of my session, there are 3.1 and 3.2. So here we start with the management of HIV-exposed infants and children. So just a brief background on who are the HIV-exposed infants and children. So these are the infants and children born to mothers infected with HIV. And because by virtue of being born to these mothers, they are exposed to HIV. So until the time that HIV is completely ruled out in these infants or confirmed in them, they carry the risk of maternal to child transmission and therefore are exposed to HIV. So to give you a background, in 2020, a study was done and it was estimated that 81,430 children were infected with HIV. And this comprises 3.5% of the total number of people infected with HIV. This was also amounted to 10% of new cases of children with HIV. And a sharp decline was seen of 55% in the annual new infections. And this decline seen in children mimicked the decline that we saw in adults as well. So to summarize the HIV pandemic and the epidemic in 2020, so we had a total number of 23,18,738 people infected living with HIV at the time, of which children comprised only 3.5% of that population. But if you look at the AIDS-related deaths, the total deaths seen were 31,944, of which children, were proportionally 12% of those deaths were seen in children. So as you can see, even though the number of children infected is only 3.5% as compared to the total population, the deaths were much higher, to 12% in proportion to the entire population. And therefore, this tells us that children are far more vulnerable to HIV and more likely to die due to HIV. So hence the need to, look after them more closely. So maternal to child transmission of HIV accounts for almost 90% of all the HIV infections in children. And therefore, in India, it was estimated that almost 30 million pregnancies occur every year. And of these 30 million, it is estimated that 20,520 of these women are infected with HIV. Now, these women may know that they're infected with HIV, or they may not know and maybe, detected to have HIV infection during their pregnancy. But infants born to these women infected with HIV are at risk of acquiring HIV infection. So it is our duty as doctors to, catch those women, to screen all the pregnant women for HIV and pick up those who are infected and treat them with antiretroviral therapy, because we have very good antiretroviral drugs that can prevent maternal to child transmission. And it's important to catch them and treat those mothers to prevent their children from getting HIV. So although the rate of mother-to-child transmission, was 27.4% in 2020, and there was a sharp decline from 40.2% in 2010, we still have a long way to go. The target to be reached is 5%, and a lot has been done, but still a lot more needs to be done. So coming to the risk of HIV transmission in mother-to-child health with and without any intervention. So back in the day, before antiretroviral drugs came into existence, these mothers, the risk of transmission of HIV from mother to child was a whooping 30 to 45% with breastfeeding. Now, with good antiretroviral therapy and 3 antiretroviral drugs given to the mother, this risk has dropped down to just 2% with breastfeeding and 1% without breastfeeding. So you can see that what a sharp decline we have managed to attain. But we have to advocate this and make sure that all our mothers are detected to be HIV, those who are detected to be HIV are started on antiretroviral therapy in order to bring that decline into practice. So why are the HIV exposed, infants so vulnerable? So we know that the children born to HIV exposed, those infants who are HIV exposed may not end up becoming infected, but they are at an increased rate of malnutrition, growth failure, developmental delay, infectious diseases, etc. And this is largely because of the poverty, broken families. We've seen so many families in our practice where the moment somebody is detected to be HIV, they're stigmatized. One spouse may leave the other spouse, because they are HIV positive, so on and so forth. So this disease is not very well accepted in society as we would like it to, and therefore these children run the risk of being malnourished, delayed, and having infectious diseases. And there's also a disease progression seen very rapidly in young children who are infected with HIV, especially in the first few months of life, leading to death. So this is something that we need to change and be aware of. So the mortality amongst infants, with HIV without care and treatment is almost 1/3 in the first year of life and almost half in the second year of life. And coming to the care of the HIV-exposed infant and child, the components of care of the HIV-exposed infant and child, the first is the immediate care at birth, infant feeding, then antiretroviral prophylaxis given to the infant, immunization, vitamin A supplementation, cotrimoxazole prophylaxis, growth and development, early infant diagnosis, and follow-up. We'll cover each of them in detail. So with regard to the immediate care at birth of these HIV-exposed infants, so largely the care is quite similar to those who are HIV unexposed. That is the normal infants who are born to HIV uninfected mothers. So I know most of you may not attend deliveries, but you can pass this information on to your colleagues who are attending deliveries. And by and large, universal precautions should be taken by the doctor attending, the pediatrician attending the delivery, as well as the gynecologist. So because one does not know that mother who comes in labor is HIV infected or not. So it's best to take universal precautions in all cases. So the baby's mouth and nostrils should be wiped as soon as the head is delivered. The baby should be handled with gloves until all the blood and maternal secretions have got washed off. The cord should be clamped soon after birth and milking should be avoided. Cover the cord with gloved hands and a gauze before cutting to avoid blood splattering. And initiate feeding within the first hour of birth according to the preferred and informed choice. Now, here I will make a mention that although the risk of transmission of HIV is very small through breastfeeding, the option of both replacement feeding and breastfeeding should be given to the mother and discuss this with her during pregnancy. One should not wait till the delivery to discuss this because the mother is already very tired after delivering a baby. That is not the time to discuss what choice of feeding option she would like to opt for. So it's best to have this discussion with the parents, with the mother, before the baby is born during pregnancy so that an informed decision can be made in this regard. So with regard to the guidelines of feeding infants less than 6 months of age, what we advocate and our guidelines tell us is that breastfeeding along with concurrent ARV intervention provides the greatest chance of HIV-free survival of the infant. So breastfeeding provides the infant in all required nutrients and immunological factors. Exclusive breastfeeding is to be given to all HIV-exposed infants. And from 6 months of age, complementary feeding along with breastfeeding is to be started. Complementary starting and breastfeeding to be continued. Breastfeeding can be continued right up to 12 to 24 months of age. And information regarding alternative feeding options, their advantages and disadvantages are to be provided to the mother during pregnancy. As I mentioned earlier, even though the risk of transmission is very small, the mother should be given an informed choice to decide whether she wants to breastfeed or give replacement feeding to her baby. And exclusive replacement feeding, as we have seen in our studies, is that it's not a viable public health strategy in India. So although breastfeeding is the norm, one has to inform the mother and give her the advantages and disadvantages of both options. So with regard to the national guidelines for HIV-infected infants less than 6 months of age, the mothers should be motivated to provide, I got it. The mother should be motivated to provide exclusive breastfeeding for the first 6 months of life. Where exclusive breastfeeding is not possible for the mother, for example, if she wishes to breastfeed for just a few months, for 3 months, and then cannot breastfeed thereafter, she should still give that breast milk to her baby for the first 3 months, and then later on she can switch over to replacement feeding. Now, this is a change in guidelines. So this basically entails that because we have good maternal ART, and maternal ART is given to the mother right through her pregnancy, during labor, in the postnatal period, lactation period, and lifelong, this maternal ART can reduce the viral load to a great extent, thus reducing the transmission of HIV even in the context of mixed feeding. So this is a change in guideline that we should be aware of, because earlier mixed feeding was not advocated, but because we have good maternal ART, if the mother wishes to breastfeed and later on give top feeds, that is also possible. HIV-infected mothers of HIV negative or status unknown should exclusively breastfeed their infants for the first 6 months of life, and introduce complementary feedings from 6 months of age. Breastfeeding can be continued alongside complementary feeding right up to 12 to 24 months of life. Breastfeeding should only stop once a nutritionally safe and adequate diet can be provided without breast milk. So ensure that the infant is getting adequate nutrition if the mother chooses to stop breastfeeding completely. And exclusively replacement feeding may be considered in situations, for example, where the mother has expired, or the mother is very sick, or the baby is given to an orphanage for adoption. In such scenarios, exclusive replacement feeding may be considered, or if the mother, opts for replacement feeding as well. So what are the benefits of breastfeeding and replacement feeding? So we've seen that exclusive breastfeeding has a whole host of benefits. It provides all the nutrients that the baby needs in the first 6 months of life. It's easy to digest. It protects the baby from diarrhea, pneumonia, and other infections. It is readily available, does not require preparation. Breastfeeding helps develop mother-infant bonding. It helps the mother to recover from childbirth early, and even protects the mother from getting pregnant again soon. Although breastfeeding runs a small risk of being a transmission of HIV as long as the baby is breastfed, the benefits far outweigh the risks. With regard to replacement feeding, even though the risk of HIV transmission is completely eliminated, there is the expense of obtaining milk, water, fuel, cleaning the utensils. Babies are found to be at a higher risk of contracting diarrhea, pneumonia, and infections with replacement feeding, because the antibodies that breast milk gives are not present in replacement feeding and top milk. And of course, the mother may be questioned as to why she's not breastfeeding her baby. So there are disadvantages involved, and one has to, weigh the pros and cons of each of them before advising either or both of them. So with regard to replacement feeding, the 6 criteria to assess whether this mother is capable or should be opting for replacement feeding is: one is, first, the mother should have access to safe water and sanitation at the household level. She should reliably afford sufficient and sustained replacement feeding. So she should be able to buy the milk and be affording in that regard, because many of our mothers cannot afford that extra expense. So that should be looked into. It should be taught to her how to prepare the feed in a clean manner, and it should be given for the first 6 months of life. The family should be supportive of this practice, as I mentioned earlier. It involves financial aspects, fuel, etc., and even the social aspect that the mother's not breastfeeding but giving replacement feeding, etc. And access to healthcare if the child falls sick. So the mother should be counseled regarding the feeding strategy, and a choice should be made during pregnancy. With regard to mixed feeding, as I mentioned earlier, in the continued presence of maternal ART, mixed feeding is also rendered safe and may be preferred over no breastfeeding at all. So although exclusive breastfeeding is recommended for the first 6 months of life, mixed feeding is not a reason for stopping breastfeeding, because if the mother is on antiretroviral therapy, her viral load is suppressed, it is safe to breastfeed, and it is also safe to mix feed if required. With regard to complementary feeding, the principles remain the same for both HIV-exposed and unexposed infants. We introduce complementary feeding at 6 months of age, initially in small amounts, and then gradually increase both the quantity and frequency. you also increase the consistency, and by 1 year of age, the child should be eating from the family pot. And this nutritional complementary feeding is, cue based. When the child is hungry, he should be fed. There should be not any force. There shouldn't be any force feeding at all. And only when a nutritionally adequate and safe diet can be given to the baby, only then should a decision to stop breastfeeding be taken. Iron-rich foods also should be given, and a well-balanced diet, if given to the baby, one does not need to give vitamin and mineral supplements at all. With regard to infant ARV prophylaxis, so now this is a change in guideline, and I want all of you to closely look into this, as well as provide these guidelines both to the birthing place, to the obstetrician, gynecologist, to your PPT-CT counselors, as well as your pediatric friends who are attending deliveries. So now we have categorized our infants based on the risk status into low-risk infants and high-risk infants. So the low-risk infants are the infants who are born to mothers with viral suppression, whose viral loads are less than 1,000 copies per ml. And this viral load should be done in the mother after 32 weeks of pregnancy, right up to delivery. So if her viral load is suppressed, then only a single drug, nevirapine, is given to the baby from birth right up to 6 weeks of age. In the event that nevirapine cannot be given in certain situations, as I'll tell you right now, zidovudine is given to the baby. So zidovudine is given only to an infant who is born to a mother with confirmed HIV-2 or HIV-1 and 2, both combined infections, or if the mother has previously received a single dose of nevirapine during an earlier pregnancy or delivery, or if the mother has failed on treatment and is now on a PI-based ART regime. In these three situations, zidovudine can be given instead of nevirapine. But one must ensure that at your birthing place or wherever the delivery is occurring, both nevirapine and zidovudine are both available at that center. Now, with regard to the high-risk infants, these are the infants who are born to HIV-positive mothers who are not on ART. So maternal viral load has not been done, after 32 weeks of pregnancy, or the viral load is not suppressed after 32 weeks of pregnancy. The mother may have been newly detected. Her viral load may be very high at the time. And therefore, she is the infant born to her is a high risk of transmission of HIV. And a mother newly diagnosed, within 6 weeks of delivery, is also her infant is also a high risk infant. So in the case of high risk infants, a dual prophylaxis is given with both nevirapine and zidovudine, and the duration of this dual prophylaxis is decided on the type of feeding. So in the case of exclusive replacement feeding in such infants, the dual prophylaxis is given from birth to 6 weeks of age. And if it is exclusively breastfed the child, then the dual prophylaxis is given for up to 12 weeks of age. So this is something that is a change in the guideline from the earlier guideline till now. And this should be widely spread. And, maybe a chart of this can be kept in the labor room and given to the PPTC counselors as well as in your ART centers. And these are the doses of nevirapine. I won't go into details, but just to let you know that this the dose of nevirapine is weight-based. So as the infant grows and is bigger, the dose increases. And this also should be kept in your center so that it serves as a ready reckoner when you have to prescribe nevirapine to a newborn baby. The same with zidovudine. As the weight increases, the dose increases. Just a note to mention here that zidovudine is given twice a day, while nevirapine is given once a day. And the duration, as I mentioned earlier, depends, on the high risk or low risk infant and whether she's breastfed or replacement fed. So just to reiterate that if an infant is low risk of transmission, the duration of prophylaxis is a single drug, usually nevirapine, for 6 weeks, regardless of the feeding option. While if an infant is high risk of transmission, then the duration of dual prophylaxis is given for 12 weeks if she's exclusively breastfed and 6 weeks if he's exclusively replacement fed. So coming to immunization and vitamin A supplementation. So every baby has to be immunized and given the supplementation as per the national immunization schedule. So this schedule is the same for both HIV-exposed as well as unexposed babies. We follow the same schedule. I won't go into details, but just a word to mention here that if a baby is HIV-infected, for example, it is possible that they end up going into severe immunosuppression because of the HIV infection, or in those whom antiretroviral therapy has not yet been started. So one should be aware that if the child is severely immunosuppressed and has a CD4 count of less than 15%, then giving live vaccines such as measles, a measles-based vaccine, or even Japanese encephalitis. I understand Japanese encephalitis vaccine is only given in certain states of India, especially in the northeastern states and not all over the country. So these vaccines should be avoided in those who are severely immunosuppressed. But by and large, all the other vaccines can be given to the child, and they are very safe. So just a word about immunization, that these children are very susceptible to infection and therefore should be immunized against all the vaccine preventable diseases. They should be immunized on time. No delay should be made, or waiting for CD4 counts and things like that to come in. Immunize them on time. Live vaccines, as I mentioned earlier, only contraindicated in severely immunocompromised infants, possibly with a CD4 count less than 15%. Otherwise, they are to be vaccinated as normal as per the schedule. All the inactivated vaccines are safe, and all recommended vaccines should be given to the HIV-exposed infant. Just a word about the live vaccines again. BCG, if it is not given at birth and has been delayed for some reason, then it should be given after ART is started when the child is immunologically stable. Similarly, with measles vaccine, as I mentioned earlier, it should not be given to a child who's immunocompromised, severe immunocompromised with a low CD4 count, with opportunistic infections, so on and so forth. An additional dose may be, should be administered after ART is administered following immune reconstitution. Rotavirus, it should be given to all infants exposed to HIV because they are all vulnerable to diarrhea. But however, in the case that a child is severely immunodeficient, then it can be avoided. So it's important to give those vaccines on time before the child goes into severe immunosuppression and has not been started on ART, etc. Hepatitis B and vitamin A are to be given as per the schedule. Inactivated other vaccines that are desirable but not included in the schedule can be inactivated hepatitis A, influenza, varicella, single dose of H influenza B in children who are more than 5 years of age who have not completed the primary series and a 15-month booster has not been given earlier. Meningococcal vaccine in adolescents and HPV vaccine also in adolescents can be given. These are the additional vaccines that are not included in the schedule but may be given on a case-to-case basis if the child is virally suppressed. With regard to growth and good development, but this is very important to monitor the growth and development of an HIV-exposed infant. And I'll tell you why. The first thing we do is to check the development of the chart if the milestones have been achieved. So we use what is called the Trivandrum Development Screening Chart, and this chart is available in your guidelines, and it is very useful because you can gauge the duration when a milestone is to be achieved and what is the upper limit. For example, if a child is holding head steady, you can see the bar from normally this milestone is achieved between 2 and 5 months of age. So if by 5 months of age a child is not holding his head, this is a cause for concern, and this child should be referred to a pediatrician for further assessment and clinical evaluation. So similarly, all the milestones can be slowly gauged and watched for in these children and closely watched and checked for. So development is very important because developmental delay can be an early sign of HIV encephalopathy, and this needs to be picked up early. With regard to the growth, I would reiterate that every child who comes to your ART center, be it for immunization or for the EID that's at 6 months, 12 months, 6 weeks, 6 months, 12 months, and 18 months, they should have their weight plotted on a growth chart. Every child from 0 to 5 years of age should have their weight plotted on the growth chart. And if you do this serially, you can actually gauge how the child is growing and whether they're following the growth curve. So normally in a well-nourished child, the weight is between 2 and -2 standard deviations. Anything below and above that is a cause for concern, and the child should be referred to a pediatrician to either assess for obesity or to assess for malnutrition. Malnutrition is more common, I would say. So to pick up these children very early because they may present to you very late, and to gauge their nutrition and their growth is extremely important. Along with weight, I would reiterate that the length or heads and height should also be plotted. So because stunting is very common in HIV infected infants, And we can only pick it up if a serial growth chart is maintained, if the height is taken at regular intervals at each OPD visit, if the height is recorded and plotted, then you can pick up stunting or growth faltering very early on and refer this to the pediatrician for further assessment and management. Similarly, weight for height. So if the weight for height of a child is between -2 to -3 standard deviations, this is moderate acute malnutrition. Anything below -3 is severe acute malnutrition, and then the child has to be nutritionally rehabilitated and managed accordingly to recover from this malnutrition. So most of our children who do come, who present late, who have not been picked up at the time, when the mother was pregnant, ART was not given to the mother, these children will come to you in a symptomatic state, and invariably they come to us very malnourished. And it is very important to pick up this malnutrition very early on. So plotting weight, plotting height, plotting weight for height can help you pick it up much early on before the child deteriorates and comes to you in a late stage. So coming to the diagnosis of HIV infection in infants and children. So EID is done in all HIV-exposed infants as well as those who are sick and with features suggestive of HIV, but who do not know their exposure status. So this could be an orphan child, a child who has no parents, who's not aware that the parents or the mother was HIV positive, and who's now presented to you with opportunistic infection. So every HIV exposed, this is an algorithm that's quite a busy algorithm, but I'll go through it in detail with you. First, we have the HIV exposed baby whose mother was HIV infected, but the baby is exposed. So for this, we'll follow advisory 1. I'll just have a quick brief look on advisory 1. These babies should be started on cotrimoxazole prophylaxis from 6 weeks of age. They're encouraged to breastfeed right up to 6 months of age, exclusively breastfeed, and from 6 months of age, complementary feeding can be started along with breast milk. And then one determines the age. So at 6 weeks of age is when we do our first EID testing on the baby. So just a brief word is that every HIV mother will transmit antibodies to her baby. So these antibodies in the infant may be seen positive right up to 18 months of age. So therefore, if a child up to 18 months of age tests positive for HIV, it only tells us that the child was exposed. It doesn't tell us whether the child is infected or not. And for that, we need to do a dried blood spot PCR, HIV PCR1 for HIV-1 PCR test at the ICTC center. So at 6 weeks of age is when we do the first dried blood spot for HIV-1 PCR testing. And if HIV-1 is detected on DNA PCR testing, a second sample is sent for HIV-1 DNA PCR testing. If that is also found to be positive and HIV-1 is detected on the second PCR test, then the child is labeled as HIV infected, referred to the center, and advisory 2 is followed. What is advisory 2? Advisory 2 basically tells us to continue cotrimoxazole right up to 5 years of age, manage any opportunistic infections in this child if present, start the child on a lopinavir ritonavir based ART regardless of the CD4 count, initiate complementary feeding from 6 months of age, exclusive breastfeeding right up to 6 months, and encourage breastfeeding right up to 24 months of age. And test again at 18 months of age with all 3 serological tests. So that is advisory 2. With regard to a baby who's 6 months, and before that, I'll say if the first sample is found to be HIV not detected, then this child is still exposed, should be closely monitored, and PCR to be done as and when the child turns out to be symptomatic. Now, if the first test, the DBS test, was found to be positive, and the second DBS test is found to be negative, then another DBS test for confirmatory HIV testing is done on PCR, and we rely on the results of this third test. So if HIV-1 was detected on the first test, then the child is found to be infected and referred to the ART center. If it is not detected, then again, the child continues to be monitored and ART is not started at that stage. With regard to a child who's 6 months and more, if you have a look at the right side of the algorithm, at 6 months onwards, we collect blood for HIV antibodies, and we do all the 3 serological tests on this child. We also collect a dried blood spot sample for HIV-1 DNA PCR. So if on antibody testing, the child is found to be positive, then the dried blood spot test is sent for HIV-1 DNA PCR. And if that is also found to be have HIV-1 DNA, then the child is labeled as infected and started on ART. If the child is found to be antibody negative, then the child is probably not infected. And here in this case, we follow advisory 3. Now, as advisory says, 3 mentions that repeat testing is to be done at 6 months, 12 months, or 3 months after cessation of breastfeeding. We continue cotrimoxazole till the child is proven to be negative by all 3 antibody tests at 18 months or later. If encouraged to be the child should be encouraged to be breastfed right up to 24 months of age and beyond, as the mother may want to. Counsel the mother that even though she's breastfeeding, she should adhere to her ART, because if the mother's viral load is suppressed, she's on regular ART, the risk of transmission to her baby through breast milk is very low. And finally, at 18 months of age or 3 months after cessation or stopping breastfeeding, whichever is later, an HIV antibody test needs to be done to give us a definitive diagnosis of whether this child is infected or not. So 18 months is the last time when we actually see these babies, or 3 months after cessation of breastfeeding, whichever is longer, when we can confirm whether this child is really infected or not. That is the last, we'll see before discharging him out and labeling as an HIV negative. So if a child presents to you more than 18 months of age, and if you have done a previous testing on this child, now you will by now know that whether he's HIV one has been detected on PCR or not. So even if it is detected on PCR and ART has been started, we will still do an antibody testing at 18 months of age. And if it is positive, we continue ART. If it is negative, this is labeled as serodiscordance, and you continue ART, and further testing is to be done. I won't get into this because this is a topic by itself. But just to make it clear that if antibody testing is positive at 18 months and the child is on ART, continue ART. If not, then further investigation requires to be made, but ART is to be continued. On the other hand, if HIV-1 was not detected by PCR and, it is now positive at 18 months, then the child is labeled as HIV infected. So remember, after 18 months, we rely on the antibody testing. If the antibody testing is positive, we label the child to be HIV infected, provided he's not been, breastfeeding has already stopped by then, and the child is initiated on ART. So in certain situations when a child is less than 18 months and you do not have access to virological testing or PCR testing, or the PCR, recently we had an incident where the PCR kits were not available for a time, and so on and so forth. In such a case, when the HIV antibody is reactive and the child is symptomatic, has got 2 or more of the following, such as oral thrush, severe pneumonia, and severe sepsis. In that situation, you can take a call to start ART, even though you are waiting for virological testing or PCR testing, and either the kit is not available or the report is pending. Because if this child is very sick, he has no time left. So time is of essence here. So it's best to start ART in that situation. And maybe, once you get the kits available or the virological testing facilities available, then you can do it. So this is a situation where presumptive diagnosis of HIV can be made in children less than 18 months of age who have tested antibody positive and who are severely symptomatic for HIV. So I won't get into this again because we know more than 18 months, we rely on the antibody test to label a child as HIV infected to start ART. And the diagnosis, as I mentioned earlier, less than 18 months, we always do a confirmatory PCR test and check the status of breastfeeding. More than 18 months, we only rely on the antibody testing as per the NACO guidelines. The follow-up protocol of an HIV-exposed infant. Here, as you can see, the child will visit you at birth, 6 weeks, 10 weeks, 14 weeks, 6 months, 9 months, 12, 15, and 18 months. EID testing will be done at 6 weeks, 6 months, 12 months, and 18 months. You start cotrimoxazole for these children from 6 weeks of life and continue till 18 months. However, if the child is found to be infected, then cotrimoxazole prophylactic therapies continue till 5 years of age. Again, this is the protocol we follow. So at every visit, as I mentioned earlier, the child will be counseled for infant feeding. He will be looked very closely for his growth monitoring, developmental assessment. Immunization will be provided to these infants as per the national protocol. Clinical assessment to be done at every visit. Please examine every child to look for opportunistic infections. Even though his PCR testing may have been, found to be negative and the child is not infected, he's still exposed. He does run the risk, especially if he's continued to be breastfed. So examine these children closely for opportunistic infections, and we'll cover the examination in my later slides. HIV testing, as I mentioned earlier, to be done at 6 weeks, 6 months, 12 months, and 18 months. And maternal health and her ART adherence should be ensured at each and every visit to reduce the transmission of HIV from mother to child. So I'll stop here for 5 minutes before I go on to the next topic and just ask anyone if they have any burning questions that they'd like to ask. And in the chat, everyone has wished us good afternoon to all of you.
Ma'am, we'll take questions at the end of the session, ma'am.
Okay, no problem. That's perfectly fine. So coming on to the management of a newly diagnosed HIV infection in children, including ART initiation. Yeah. So first and foremost, let's determine the clinical and immunological staging of the child, and assessment of a newly diagnosed child with HIV. So I can't reiterate the need for growth assessment as we discussed earlier, clinical assessment, developmental assessment, as we've already discussed, lab assessment, and lastly, psychological assessment. So when you see a child who's newly diagnosed to be HIV positive, one has to screen for 4S screening. Now, this is not only done at the time of a newly diagnosed child, but for every clinical visit, lifelong. They should be screened for 4S testing. They should be asked whether there's cough, fever, weight loss, or contact with TB. The age-appropriate developmental milestones should be looked in. As I mentioned, the random chart should be used for that. Behavioral abnormalities should be picked up because this could be an early sign of HIV encephalopathy. And review all the past medical documents, whether the child has had an opportunistic infection in the past, or the child is on certain drugs that may interact with our antiretroviral therapy. So look into that very closely. Assess the immunization status as well. And if there's a backlog in the immunization schedule, then those vaccines should be given to the child. When clinically examining the child, look for signs of anemia. Many of these children come to us very anemic. They need hematinics and they are malnourished. They may be having kwashiorkor, marasmus. Look for nutritional deficiency, look for jaundice. Jaundice could be even a sign of co-infection, such as, or the child may be on anti-TB medications and maybe jaundice because of that, or co-infections with, say, hepatitis B or C. Look for any fever, examine for respiratory distress, decreased activity, altered sensorium, signs of meningitis, any opportunistic infections. Parotid enlargement is seen. Digital clubbing can be a sign of bronchiectasis. Lymphadenopathy can be a sign of tuberculosis, etc. Dermatitis, hepatosplenomegaly, etc. So look for these, look for CNS signs as well. Also examine the fundus of a child to look for visual impairment and chorioretinitis. It's very important to rule out chorioretinitis in all children before starting ART because that can worsen later on. And with regard to the developmental assessment, these are some positive indicators that we look for and some negative indicators. What are these positive indicators? So if a child has lost previously attained developmental skills, so if the child was, for example, walking and now he cannot walk, he's confined to the bed, for example, and he's lost developmental skills. He was, say, crawling before and now he cannot even sit with support. So if a child has lost milestones, it's labeled as neuroregression, and this is something very seriously that should be looked into and referred to the pediatrician for further assessment. The parental concerns about vision, fixing, following, as I mentioned earlier, chorioretinitis can lead to visual impairment. Hearing loss, CMV can lead to hearing loss. Then if there's a persistently low muscle tone, floppiness, there's no speech at 18 months of age, then, or no non-verbal gestures, the child may be having a hearing impairment secondary to, a past CMV infection, etc. So these clinical clues will give you an idea of whether there's an underlying opportunistic infection, that needs to be picked up and assessed. Asymmetry of movements. If hand preference is seen before 18 months of age, this could be an early sign of cerebral palsy, increased muscle tone, or hemiparesis, or child may have had a stroke or a hemiplegia. So look for these subtle signs in the child. The mother can give you a detailed history. She can say that, my child is only using one hand and not the other. Look more closely and examine that child to pick up these early problems. Persistent toe walking can be a sign of complex disabilities. A head circumference that is either too large or too small, microcephaly or macrocephaly, should be picked up. Measure the head circumference at every visit in addition to weight, height. And if there are any concerns, be it from the parents, from the mother, or on your side, always refer this child to a pediatrician for further assessment. Negative indicators. If a child is not sitting by 12 months of age, or not walking by 18 months of age, or he's running on tiptoes, still running on tiptoes by 2.5 years of age, these are signs, red flag signs that should be, addressed very closely. If a child cannot hold an object by 5 months, normally a child does hold an object by 5 months of age, or he's not able to reach out for objects by 6 months of age. These should be picked up early. Use the Trivandrum developmental screening chart that I mentioned earlier, that as this will give you an idea of what milestones are to be achieved and when are they to be achieved. And if they're not achieved by that age, then further follow-up is required for these children. This is the Trivandrum chart that I was mentioning earlier. So you can see the red bar tells you when a milestone is to be achieved, and this is the maximum limit of the normal range. So if a child, for example, raises self to sitting position and does not do that even after 13 months of age, then this is a cause for concern, and the child should be referred to the pediatrician for further developmental assessment. So all these milestones should be looked in more closely. Coming to lab assessment. So before we start antiretroviral therapy to any child, we must do some basic investigations to assess if a hemogram or a CBC to see if the child is anemic, if the child has any underlying infections, a urine routine microscopy. Look for the fasting and random blood sugar, because certain drugs, for example, like dolutegravir, can lead to, have side effects. So it's always best to do this baseline investigations, and if required, if they do come out to be abdominal, to assess further as to why this is the problem. Blood urea, creatinine, serum bilirubin, SGPT. A CD4 count is very important, because you need to know what the baseline immunological status of the child, if he's immunosuppressed. If the CD4 count is less than 350 cells per cubic millimeter, he will be needed to start on cotrimoxazole prophylaxis. Although in children right up to 5 years of age, cotrimoxazole prophylaxis is given, irrespective of the CD4 count. Then hepatitis B and C status, do a chest x-ray, look out for any pneumonia or any signs of tuberculosis. And in certain places like Bihar, Uttar Pradesh, Jharkhand, RK39 strip may be done to rule out leishmaniasis in those states of India. And further additional testing to rule out tuberculosis, for example, doing a CB-NAT on a sputum or a gastric lavage may be important. Doing a complete LFT for those being initiated on anti-TB treatment, or those with co-infections such as hepatitis B and C. A lipid profile, especially if you're planning to start a PI-based ART regime, and an ultrasound of the abdomen to look for, lymphadenopathy in the abdomen, especially abdominal tuberculosis. So these are the baseline tests that we do on our children before starting them on ART, to rule out opportunistic infections or co-infections, as the case may be. And to also assess the baseline status, especially the CD4 count, because you want that count to increase after starting ART, and then you can monitor and compare the counts before and after ART. Initiation. The revised classification of immune suppression in children. So for children less than 5 years of age, we normally prefer the percentages. The percentage of the CD4 count is far more predictive of immunosuppression as compared to the absolute count. So for example, if a child is less than 11 months and has a CD4 count of less than 25, he is severely immunosuppressed. If his age is between 1 to roughly 3 years and a CD4 count less than 20%, again, severe immunodeficiency. And 3 to 5 years, less than 15% is also considered to be severely immunosuppressed. A child more than 5 years of age with a CD4 count less than 200 or less than 15% is also severely immunosuppressed. So this is roughly the classification we use for immunosuppression in our children. Now, with regard to pre-ART care, so although we follow the treat all policy, it is very important to realize the pre-ART care, because this is a time where we will not only send your investigations out and wait for those reports to come to, to initiate ART and to rule out opportunistic infections, but also to counsel the family and help them to prepare for lifelong ART. Because in children, adherence is everything. The child has to be adherent to therapy in order to become virally suppressed and remain healthy. So this is the time that while your investigations are being done, take the parents aside, your counselors as well as you can counsel them to know the importance of the treatment that they're taking, to understand the disease better, and to adhere to treatment as the case may be. So management of conditions, if they're found to have opportunistic infections before ART initiation, because many of our children present to us with opportunistic infection, they have not known that their parents were HIV exposed, they come in a very severe state, or the parents have passed away, there was no one to look after the child, no one knew that the child may be HIV exposed, and therefore now they've presented with a very low CD4 count with opportunistic infections. So first and foremost, diagnose and treat the opportunistic infection, and once the child is stable, start him on or her on ART. With regard to tuberculosis, ART should be started as soon as possible within 2 weeks of initiating anti-TB treatment, irrespective of the CD4 count. With pneumocystis carinii, treat the PCP first, start ART prophylaxis, ART, once the PCP treatment is completed. For fungal infections, be it esophageal candidiasis, cryptococcal meningitis, penicilliosis, histoplasmosis, you always start ART, and once the child is stabilized or the OI treatment is completed, and the child is stable enough to take your ART. The same with bacterial pneumonias and malarias. You treat the infection first. Once the child is stabilized, you start ART when the treatment is completed. Now, for drug reactions, just a word of caution that if there is a drug reaction, do not start ART at the time of that acute drug reaction, because you will not know whether the drug reaction was due to the offending drug that you started or due to your ART. So it's best to wait till the child stabilizes, the drug reaction has subsided and resolved, and then start ART, so that the reason being that certain drugs, for example, abacavir, we have seen very few cases with abacavir hypersensitivity. So that could be a cause for concern. And if you had already started another drug to which the child developed an allergic reaction, then you would not know whether this child developed abacavir hypersensitivity or, say, Septran allergy or so on and so forth. So this is just an example that I'm giving you. The same with diarrhea. Wait till the diarrhea is diagnosed and treated before starting ART. And if the child is severely anemic, treat the anemia and avoid zidovudin, because zidovudin itself can induce anemia. So ensure that if you're giving zidovudin for some reason, then the hemoglobin should be more than 9 grams. Similarly, with skin conditions and Mycobacterium avium complex, you can't start ART as quickly as possible. With cytomegalovirus infection, we treat the CMV and then start ART after the induction phase is over. Toxoplasmosis, again, same thing. You treat and then start ART after 6 weeks. And with SAM, with severe acute malnutrition, we wait till the child is stabilized. He has his metabolic complications and sepsis have resolved, and then maybe once a child is on F100, then we can start him on ART as, so usually it takes about 7 days for a child to stabilize with severe acute malnutrition and opportunistic infections. So we wait for that period of time, treat the infection, stabilize the child, and then start ART. So evaluation of an adolescent child living with HIV. So the adolescents are a different group of people, because here the child is much older. They know, they're most likely Googling and finding out about HIV. So it's important to also assess what they're going through and ask a few questions. So what we do in our clinic is a HEADS assessment. HEADS is a mnemonic that stands for home, education, eating, activity, drugs, sexuality, safety, and suicide and depression. So ask the child questions and where do you live, with whom do you live, how do you perceive your home situation, your education, how's your relationship with your teachers, what do you do in your free time. With regard to meals, what do they think of their meals, how do they eat their meals every day, where do they eat, what do they eat. Make sure that their nutrition is also, up to the mark. With the activities, what do they do after study or work, what do they do in their free time, who are their friends, who are their peers. Remember, there is a lot of social interaction, peer pressure, and this is where we need to keep a close watch on them, because things could go wrong. Drugs, whether they're, substance abuse, injecting drugs, tobacco, alcohol, how much, when, with whom, where, ask all these questions. Sexuality, whether they're having, intercourse or they're having a relationship with somebody, and what, contraceptive barrier methods are they using, whether they're aware of their status, whether the partner is aware of the status. In this day and age, we should not assume anything. It's best to ask these questions directly to ascertain what is happening in the child's life. Whether the child is safe at home, any suicidal tendencies, depression, these are very common. Remember, these children may have probably lost both parents. They're being looked after by caretakers. We don't know how well they are loved and cared for. So it's always important to ask whether they are getting that emotional support that they need during this difficult, this period of life. And with regard to antiretroviral therapy in children, so ART is to be initiated in all children and adolescents living with HIV, regardless of the age, CD4 count, WHO clinical staging. So once you confirm HIV, either serologically after 18 months of life or virologically below 18 months of age, you first treat and stabilize the acute condition, treat the opportunistic infection, do a baseline CD4 count, and then start ART. Start your first line ART, irrespective of what the clinical criteria, the WHO clinical staging or the immune staging or the CD4 count. So with regard to what regime to start and for whom, so the regimes are such that if a child is less than 6 years and a body weight of less than 20 kilos, we start abacavir, lamivudine, and ritonavir-based lopinavir. So 2 NRTIs and 1 PI. So if the age is 6 to 10 years, body weight between 20 to 30 kgs, abacavir, lamivudine as a fixed drug combination plus dolutegravir. Dolutegravir being an integrase inhibitor is a very good drug and has really changed the scenario here because we're able to achieve viral suppression with all these drugs. And if the age is more than 10 years, body weight more than 30 kgs, we follow the adult regime of tenofovir, lamivudine, and dolutegravir. Okay, each of these drugs are given on a weight-based chart. The weight-based charts are available in your guidelines, so you can refer to that. This is the formulations that are available by NACO. Just a few thoughts. The ones in yellow, the dolutegravir 5 mg and the 10 mg are not yet available, but they're due to be available shortly, and they can be used in smaller children. But as of now, as I mentioned earlier, we're using abacavir, lamivudine, and lopinavir, ritonavir, as well as dolutegravir with the 50 mg dose in children. Here is the 50 mg tablet that is being used in children above the weight of 20 kilos. A few drugs, such as the third line drugs with darunavir, etc., are not always available. We sometimes need to procure them from outside, etc. So have a look at these weight-based charts to tell you how to prescribe the drugs and how much to prescribe in these children based on the weight band. So in pediatrics, everything is weight band related. Depending on the weight, the dose is accordingly adjusted. Now, in certain situations when the child is on TB medication, in addition to lopinavir and ritonavir, in those babies who are on rifampicin-based anti-TB treatment, a super boosting is done. A super boosting, which an extra dose of ritonavir is given, and this dosing is given in this chart, Annexure 2. I won't go into in detail. And this is primarily if the child is having lopinavir, ritonavir, or a PI-based ART regime, in addition to a rifampicin-based anti-tubercular treatment. So again, the choice of ART regime in the child, we confirm the status, treat the opportunistic infection, do a baseline CD4 count, prepare the child and the family for lifelong ART. As I mentioned earlier, if it's less than 6 years, less than 20 kilos, give them abacavir, lamivudine, and lopinavir, ritonavir combination. If it's 6 years to 10 years, weight 20 to 30 kilos, abacavir, lamivudine, and dolutegravir. More than 10 years, more than 30 kilos, tenofovir, lamivudine, and dolutegravir. Now, a few special situations that I'll mention, again, to co-infection with TB. If you're using a DTG-based regime, as I mentioned earlier, you may be using abacavir, lamivudine, and dolutegravir, or tenofovir, lamivudine, and dolutegravir. If there's a co-administration of a rifampicin-based anti-tubercular treatment, you double the dose of dolutegravir. That means you give dolutegravir twice daily instead of once a day. And this continues right up to 2 weeks after the last dose of rifampicin. So even after stopping the 6 months of AKT, you continue giving the extra dose of dolutegravir 12 hours apart for 2 weeks after the rifampicin has been stopped. Similarly, with the lopinavir, ritonavir based regime, super boosting of the lopinavir with ritonavir in the ratio of 1:1. That means the dose of ritonavir is stepped up to be 1:1 with lopinavir. And this is called super boosting. And this is to be also given alongside the anti-tubercular treatment. And this super boosting is to be continued for 2 weeks after stopping rifampicin. With regard to efavirenz-based regimes, we are pretty safe. There's no modification is required. And DTG with lopinavir, if both have been given as an ART regime, then again, you double the dose of DTG or dolutegravir. You give 50 mg twice daily. In addition, you also do the super boosting of lopinavir with ritonavir in the ratio of 1:1. And both double dose of DTG and super boosting of lopinavir with ritonavir is to be continued for 2 weeks after stopping the rifampicin. So just this to be kept in mind if there's a co-infection with tuberculosis, because there is an interaction of rifampicin with dolutegravir, and that's the reason we're doubling the dose of dolutegravir. Similarly, there is an interaction with rifampicin and ritonavir, and therefore we are doing the super boosting. So because they are cytochrome enzyme inducers, we need to give these extra doses to prevent any drug interaction and ensure the drug levels are maintained throughout. Again, with regard to ART and initiation of TB, you first treat the TB, and ART is to be started within 2 weeks of initiating tuberculosis treatment, irrespective of the CD4 count. And with children living with TB meningitis, ART can be delayed or should be delayed for actually 4 weeks and initiated within 8 weeks after starting tuberculosis treatment for TB meningitis. Corticosteroids can be used as an adjuvant therapy in TB meningitis. So this is a situation where TB meningitis is being a serious infection, is treated, given 4 weeks of anti-tubercular treatment, and then ARTs is started. Again, I mentioned earlier with the co-infection with TB that you give a fixed dose. If the weight is less than 20 kilos and age less than 6 years, you give a fixed dose combination of abacavir and lamivudine twice daily as per the weight band, and lopinavir ritonavir with super boosting of additional ritonavir twice daily as per the weight band, as I mentioned earlier. With the weight of 20 to 30 kilos and aged 6 to 10 years, again, the same thing, abacavir, lamivudine twice a day, and dolutegravir twice a day. So normally it would be given once a day, but because of the TB co-infection and rifampicin-based AKT, we give dolutegravir twice daily. Weight more than 30 kilos and age more than 10 years, tenofovir, lamivudine, dolutegravir once daily with an additional dose of dolutegravir after 12 hours. So both the DTG as well as the super boosting should be continued for 2 weeks after the last dose of rifampicin. And with that, I end my lecture. Thank you so much for a patient hearing.
Thank you so much, ma'am. Any questions from the participants? Please feel free to put them in the chat box, so you can unmute your mic.
I'll just stop sharing my screen and so that we can take questions. Thank you all for a patient hearing.
Any questions from the participants? Please feel free to unmute your mic. You can also type in the chat box. Ma'am, I don't think there are any questions. Can I go ahead with the feedback form, ma'am?
Sure.
The feedback poll is now visible on your screen. Participants are requested to please answer all the 4 questions. Thank you so much, Noella ma'am, for facilitating this session.
Most welcome. My pleasure.
Thank you to all the participants for patient listening. Ma'am, can we conclude the session now?
Sure. If there aren't any questions, I'm happy to.
No questions, ma'am. Thank you so much.
Most welcome. Thank you all for a patient hearing.
Thank you, ma'am.
Thank you.